It's a sincere pleasure to introduce Dr. Richard Lester. Rich, I guess we met, about a year ago or so. Rich actually was from BC, went to the University of Manitoba, and the BCCDC, British Columbia Centre for Disease Control, was very smart in getting Rich back, I think. And since he's joined back in 2009, I think he's making a major splash in Eat Health, and has been on CBC television recently, has been in Nature for some of the real seminal work that he's doing in this area. So it's a real pleasure, and it's important to show the community some of the great, neat stuff that's going on right here at the University of British Columbia. So thank you so much, Rich, for taking time out of your busy schedule. I think you were in clinic, right? You were saying, and you're pretty busy right now. So with my pleasure to introduce Dr. Richard Lester. Rich?
So thank you, Keisha. I think this is, can you hear me? Am I going through? Hello? Okay. I think this
I'm
is...
shorter than you.
Yeah. My interest has actually been basic science, and this is something that branched off that's quite far from basic science and approaches more the access side, which I think is can all come together. But I have to say, I think the concept of NGDI is great, because really the foundations in science. I know in Kenya, when we one of our favorite trees out on safari are fever trees, and that's because they cause malaria, or they cause fever, which without science we wouldn't even know that it was malaria and mosquitoes and other things like that. We can make all kinds of assumptions and associations. So the science is really the foundation for all the that we're doing, and that goes all the way up to the innovation for communications that allow us to have these presentations and know what's going on around the world. So I appreciate what NGDI is doing. Also have to say I'm less strict on what Keish said about turning off your cell phones. I think you might think of them as a lifeline, and I don't think you need to turn them off, but maybe text message, because that's less of a nuisance to the people beside you, so just don't talk on them. Thanks. So one of the biggest challenges, I said the biggest challenge, but I think the biggest challenge is health systems and equity, as has been pointed out already. But one of the biggest challenges in infectious disease is still HIV, and it's still outpacing resources globally. And there is treatment available. Antiretroviral therapy is now long known to reduce viral replication, improve health, and save lives and restore health in individuals infected with HIV. And there's a lot of work in scaling up. But when you look at the scale of the disease and the scale of the problem, it's still neglected for many people in many populations. But I think the real key is everyone's seen the map before with the global distribution of HIV prevalence being very heavily focused in sub-Saharan Africa and other impoverished areas. And the real struggle is not only the medications and technologies, but, well, it is the technologies, but it's also the health systems that are required to deliver the therapies. And with HIV, antiretroviral therapy it's not just a one-off vaccine or a one-off cure. It's actually a dramatic challenge, because it means taking medications still twice a day for most populations. For the rest of their lives. We know that as soon as one doesn't adhere properly or stops taking their medication, the virus starts replicating again, because it's been integrated into their bodies and comes back. So it's a lifelong challenge for an individual, which means it's a real challenge for health systems to support that. And because that challenge is existing primarily in areas with less resources, the systems really need to be effective, as we all agree, but they need to be very efficient, and I think just as important, they need to be resourceful and really rely on local ingenuity and local resources. And then they have to be durable, as we said. It's not just HIV isn't going away quickly by treating it all. We need to treat, and we need to maintain a sustained response and prevent cost escalation. So we know that adherence is a major factor in that. If people take their medications, start taking them well even, but don't take them consistency, then the virus has a chance to rebound. It mutates very easily. Drug resistance develops, requiring new medications, more expensive medications, and incredible cost escalations. So with spending all that time and introducing the background on the first slide, we'll move ahead. But we look at infectious disease and outbreaks and pandemics, and the slide on the left is the HIV prevalence map in Kenya. But if you looked at an outbreak that was occurring on the slide on the right, that's actually the Safaricom network coverage in the country, which is actually, we used this the other day, but going viral in that really you see that the coverage of cell phone networks are expanding extremely rapidly throughout regions and faster in Africa actually than anywhere else. So we have two things going on spreading rapidly. We have communicable diseases and ill health, and we also have tools that may be used that are expanding rapidly. And the nice part about that is that's not expanding through foreign aid or top-down type of approach. It's basically expanding by free market and the resourcefulness of the people that are living there. So I went to Kenya, actually, to do vaccine research, immunology research with Frank Plummer's group. And there was a tremendous group, and I just have to thank Frank for the chance when basically the opportunity to ask new questions and do what you want. I'm not sure if he thought that I'd be doing cell phone trials as a part of that, but when we arrived there, we realized that it wasn't Swahili we needed to learn as the first language. It was actually text messaging, because that's how people communicate in that location, in that region of the world, and it's very effective. It doesn't interrupt you when you're talking to someone else. You can get a text message, but it's a little bit more urgent than email, certainly more accessible than email in this part of the world at this time. So we looked at Kenya and its population, as I mentioned, a very resource-limited setting, but a huge outbreak of cell phone usage, and thought how, at the same time we were trying to scale up our antiretroviral care programs in the research program, and we looked at, well, how can we use this cell phone revolution, basically, to help with our scaling up and management of getting treatment to people, or getting people to be optimally treated for HIV. So we did a survey, and I think it was one of the important things to do is really look at the population we're planning to do and see and identify what the existing attitudes and gaps in knowledge and so on are. And we found that so the research program there focuses in a very poor area of Nairobi, generally sex worker clinics that are, poverty-driven sex work for the most part. And we asked people attending the HIV clinic what was their we asked them their incomes, and we also asked them, did they have a cell phone, did they use a cell phone, and had they ever used that cell phone to communicate their health needs with the clinic. And we found that almost 90% used cell phones, despite making often less than $2 a day, less than $5 a day. And over half of them already owned cell phones, and they're used for everything from keeping in touch with family up country to organizing their business, whatever that business is, whether it's sex work and clients or whether it's selling shoes in the market nearby, and supply and so on. But when we asked them had they ever texted or communicated to their healthcare providers using their cell phones, since they're doing it for everything else, the minority, it was only 12% at that time, said they'd ever called someone at the clinic or been called by the clinic. So there was a big gap in this amazing tool that's being used to improve so many aspects of their life on one hand, and on the other hand, we weren't using it yet for their health management. So we got together all of the clinic staff, first of all, and that includes everyone from the nurses, the doctors, the counselors, the drivers, the lab staff, and some patients that were at the clinic, to come up with what we think is the best solution to overcome this, or to integrate the use of cell phones into the antiretroviral care program. And by doing that, by including the frontline workers and patients, I think, as probably more important evenly, because they don't have the same predefined perceptions, So we asked patients what would work for you, what we came down to is it wasn't actually the reminder, and there are a lot of studies out there looking at twice-a-day reminders. You can get digital. You can set your watch to do a reminder. Adults usually already have their reminder mechanisms built in, and they work or they don't. But it's the support aspect, and by checking in on people frequently, by doing a text message every week that just asks them, how are you, which is mambo, Swahili and mambo, and their response is either fine, sawa, or problem, shida, that would give the chance to basically provide a link of support without being too frequent, so doesn't cost so much. Also, many people don't have credit on their phones at all times, so they need some flexibility with that. So we went with the simplest thing we could come up with that we thought would have the greatest reach into the communities we were looking at. So very simple protocol. It's SMS once a week from the nurse or clinical officer cell phone to patients on antiretrovirals to ask them, how are you? And they respond fine or not fine. If they're not fine, the nurse or clinical officer will call them and triage the problem, whatever it is, whether it's a problem with medications or health or otherwise. And if in this protocol, anyone who didn't respond with a text message within 2 days was also given a phone call from the nurse or clinical officer. I'll actually maybe skip it. There are a couple of videos I have that were actually done. One, the CBC one, but the South African Broadcasting Corporation did a video, and it's nice because it shows the patient perspective. As scientists, we always tell the data story, but journalists like to tell the personal story. So maybe at the end, if we have time, we can watch one of those. But that being said, I think there's nothing could have been more important to us. Me as a scientist, I was looking at it as important to have an evidence base, but it turns out that by doing this clinical trial, we're one of the first to really do a clinical trial. There's a lot of exciting innovation and ideas regarding cell phone usage for prevention of infectious diseases, for treatment, and so on. But we wanted to be convincing to change policy, and really by doing a clinical trial, we could hopefully show that our intervention works and then therefore influence policy. So our hypothesis was that cell phone intervention through SMS texting and regular communication with patients, and that's the important part, would improve antiretroviral adherence and health-related outcomes. And our primary outcomes to look were self-reported adherence and viral suppression. And really, self-reported adherence has, I think it's important, the patient's perspectives, but it has a lot of issues associated with self-report. But the bottom line is, do people have the effect of the medication, which is a suppressed virus? So our primary outcome was also a suppressed virus after 12 months of taking antiretrovirals, which we would expect it to fall to undetectable levels and hopefully stay there. So our primary outcome was undetectable viral load after 12 months. And so we did publish the protocol as well in trials, and we registered the trial. And it's completed now, so I'm quite excited to be able to discuss the results, although they're currently under peer review, so they're really just for this audience. But we did two study designs. I'll talk about the first one. One is new patients starting antiretrovirals. We getting them off on the right foot, looking at how do they have a suppressed viral load after 1 year. Or experienced patients. There's already, as you'll see in a few slides, several million people on antiretrovirals, and they also need to keep taking them for the rest of their life. So we want to know, is there a booster adherence effect by introducing the SMS protocol after they've already been on them for a while? And that data will be coming down the road. So we enrolled 3 different sites, and again, taking as much of a practical approach as we could. We were looking at what's representative of the HIV epidemic as well as the treatment programs in the region. So we actually included 3 very different clinic settings into the same trial. That's a bit of a risk because if you get a more variable population, it's harder sometimes to show a definitive outcome. But on the other hand, if we do that, then we're showing that it's representative of something that could be scaled up. So the Pumwani Hospital was linked to the sex worker clinic, but it's a general population antiretroviral clinic in a low, poor area of Nairobi, urban Nairobi. Coptic Hospital is a faith-based clinic that, or faith-based hospital associated clinic, and serves a higher income area, still free medications. And Caggiato is a rural district government-run hospital in a primarily Maasai pastoral area over a very vast district where people travel large distances to come, and very under-resourced. So we recruited patients, all adults, starting antiretrovirals, who had access to a phone from all of these sites. And by access to a phone, they didn't have to own a phone. There are lots of clever ways that people use. First of all, I know when we go traveling and we need to know where to get cell phone, they'll say that baobab tree over by that hill, you'll get Safaricom. So if you go there, you'll be able to get your text messages. And also people share them. They either have businesses where they share their phones, or through family they often share. So really they've come up with most of the solutions, and we were just, as a group, trying to harness those for better health outcomes. And it was actually, we powered the study basically to show a 10% improvement in adherence, which we thought would be important. And we enrolled 538 people into the randomized trial, and it was and it's just been recently completed. So the baseline characteristics of those that were enrolled, one of the comments as we were debating it in the first place was the gender balance and power balance and cell phone access. We talked a lot about access, but we found that actually, so access, enrollment into the trial was over 60% women, and which is actually consistent with the demographics of the epidemic in the region. So clearly they were, at least for study purposes, we're accessing cell phones and using them. And the age distribution is also very reflective of the general pandemic in the region. The median age was 36, but we had actually at least one woman over 80 years old who was starting antiretrovirals in a Maasai community. And in terms of, we didn't provide cell phones. We initially asked to provide some, and the CDC through the PEPFAR program didn't allow that. And it turns out we had pretty good access anyway. And if you look at the level of education involved in participants, in Caggiato, the district area, almost 30% actually said they had no formal education, not even primary. Occupations varied from, there were a number of pastoralists also in the Caggiato, businessmen, but almost a third overall were also unemployed, yet they had access to cell phones and were able to participate. In terms of baseline phone access and ownership, no phone was 15.5%, and that means they shared phone access. They didn't own their own phone, but to be in the study, that whoever they shared the phone with also had to agree to be a participant in the study. So that was often could be a family member, a friend, or whoever they chose. Almost nobody had landlines, and the few people who had landlines also had cell phones. First of all, landlines are very expensive. They don't work as well. We disconnected ours after about 3 months of living there because there was just no need. Nobody would be crazy enough to call you on your landline. But it really reflects this leapfrog technology of basically no phone access to widespread access of the latest technology. And I can tell you that most 5-year-olds at that time, well, say 8-year-olds, knew how to text message in Kenya, and I came back and I was teaching at St. Paul's Hospital and the medical residents. I was teaching them with their advanced education how to text message. And in terms of language too, the language wasn't such a barrier. We had a number of, for instance, there were a number of cases. One that there's one lady, a Maasai speaking, that didn't speak Swahili either. Her grandson, who was 8 years old, used to receive and send the text messages on her behalf, whether her grandma was fine or not fine. That kid had no idea that she was infected with HIV, and it wasn't really relevant for the system. All that was relevant that someone was communicating on her behalf. And at baseline, we asked about discussing HIV on the phone as a potential barrier. As mentioned, we didn't send any information that would reveal their HIV status by the text messages, but their discussions thereafter could involve discussion around their health. And generally, the nurses and clinical officers are very professional at dealing with that anyway. But the vast majority said they would be comfortable talking about HIV on the phone. In terms of travel investments, it's a big barrier to people accessing care. In Caggiato, in the rural district, you can see people are traveling as much as 600 kilometers to the clinic. And if you look at the slide on the left, which is very difficult to read, but the left bar is those who walk to the clinic. The next bar is public transport, which is the vast majority how they get to the clinic. And then very few cycling or driving. And you can imagine if one of the side effects of either HIV or the medications is diarrhea, that jumping on a packed matatu, which is the minibus, to get to the clinic to sort out your problem, that a lot of people probably die rather than do that, and or just can't think of ways to get there. So at least by being in contact, cell phones had this ability to talk to people where they were in their setting and overcome. Now, it doesn't solve all of the problems, but it certainly makes the nurse or clinical officer help them triage the problem and get the best care and advice they can. And on the other hand, it could also mean this huge travel investment could sometimes be could be avoided, perhaps, by reassurance for problems that didn't require them to come all the way to the clinic. So if we look at the results of the study, we had nurses kept logs every week for all the SMSs that went out and the responses. We don't have all the details yet, which I think is going to be some of the most interesting data, but there's an awful lot of responses to sift through. But in general, the response rate was over 60% responded they were fine. About 30% didn't respond, and then overall 3.3% responded every week on average that there was a problem. The interesting thing with that is in the first 3 months, and this is people starting antiretrovirals, that's when the most problems were identified, 6.1%. But thereafter, that came down to about 2%. And the real power of that is that the most unstable period of starting of illness and complications is in the first 3 months, and that's been shown in other studies. So during this time, more people were reporting problems and therefore getting advice. But thereafter, fewer problems were reported, making it seem quite efficient. So now, of some concern, perhaps, are the non-responders, and basically, the non-responders who didn't respond by 48 hours were called by the nurse, and almost all of the time, it's because they just they said they didn't have credit or this excuse or that excuse, which is fine and understandable, but it was almost never a health issue. If it was a health issue, the investment of a five shilling text message was worthwhile, and they sent a Sheeta. So we were less concerned overall with the non-responses, and that's something we'll work into the efficiency of the system. But if you look at the Sheetas, 33 or 3.3% means if one nurse was supporting 1,000 patients in the field, she'd only be responding to 33 problems each week, and likely those are the people most in need. So it's a very efficient system, and when discussing with some people from the Ministry of Health in Kenya, rightfully one of the first questions they had was, well, this is going to be very resource intensive and is this going to be just too much to take on for our workers? But we found actually it was very efficient, and they were able to focus on the people most in need. So I'm excited to show the primary outcome results in that we had the very positive feedback from the group. So self-reported, we did intention to treat analysis, which is basically saying that whatever group they were randomized to, receiving the SMSs or the standard of care, and the standard of care was whatever they were receiving for support without the study. The SMS group was receiving the weekly text messages. And if they were randomized to that group, we considered them in that group, regardless of whether they continue to follow up. And any lack of follow-up was considered a failure. So self-reported adherence greater than 95%, and this is at both 6-month and 12-month visits, so really near perfect adherence. was higher in the SMS group at 61% versus 49.8% in the control group, with a significant p-value. And viral suppression, those having a viral load less than the level of detection of 400 at 12 months, was also higher in the SMS group, 57% versus 48%, with a significant p-value at a cutoff of 0.05. We also, for interest, looked at those who did follow up. So in the intention to treat analysis, we include those that dropped out from loss to follow up, attrition, death, and other causes. So we think that's actually the most robust and most important from a program point of view. But from an individual point of view who actually followed up through the program, we looked at that as well. And adherence, self-reported adherence actually didn't show a difference, but viral suppression was still significantly improved at 12 months in those that showed up for a 12-month visit. And the secondary outcomes are actually quite important, I think. Retention is probably in the program is probably the biggest challenge, actually, is reducing loss to follow-up and people starting in a program and staying in a program. So total attrition was not difference between the two groups. Loss to follow-up may have had a trend towards improvement. They all favored the SMS group, although not significantly. Interesting mortality, we actually expected a bias towards reporting in the SMS group because deaths, this is a community-based study where people are in the community, not in a hospital setting. So finding out about their deaths really requires reporting of the death. And that's a challenge. So anyone in the SMS group who stopped SMSing would more likely to be follow-ups. We expected actually a bias towards that, but there were fewer deaths reported in the SMS group even than the control group. One of the challenges is that the study was so popular, and that was a challenge from a scientific point of view. We have some colleagues from Georgetown University, health economists, who thought that this was great because it makes it very scalable in an easy way. But basically, we had people in the study, even if regardless of whether they got the intervention or not, tended to do better than those not in the study. And that's not surprising. We know that people in clinical trials have closer follow-up and often do better. But we also looked at however close you were to being in the study. And the reason we did that is we found that the nurses were reporting that people in the control arm who weren't supposed to be getting the SMSs but knew about it were calling them a lot more than anybody ever did. And not only that, in focus group sessions, we were finding out that participants who were getting their Monday morning, how are you, were forwarding it to their cousin or aunt or sister who also had HIV and felt that they wanted to give them the same level of support. So in a way, it would be hard. We didn't introduce contamination ourselves, but through popular spread of the communications, we were actually having quite a bit of intervention contamination into the control group. So we looked at those who were in the study versus those who are just in the clinic in general, the same clinics. And then we also looked at those who are in the clinic, who are a bit closer to hearing about the study, versus other clinics run by the same programs. And in every case, it seemed the closer you were to being in the study, the more likely you were to report better adherence. And Pamwani, Caggiato, and Coptic provided some of their own data for that. So in terms of just looking now at within our study, the intervention SMS group versus the control within the study, we found a significant improvement. And if you look at that in terms of absolute and relative risks, the number needed to treat, and I'll focus on viral suppression because I think that's what we really care about. The medications are meant to suppress the virus so that people don't develop drug resistance, so that they restore their health and have a survival benefit. The number needed to treat is 11.3, meaning that if basically for every 11 people enrolled, you would expect one additional person to have a suppressed viral load at 1 year. If you look at WHO and UN statistics and UNICEF statistics, there's still a long way to go globally, of course, with antiretroviral care, despite all the efforts. and we hope they continue. So currently there are 4 million people receiving antiretrovirals in the world, and it's estimated that using current guidelines, 9.5 million people are in need of the medications, with a 42% coverage of those who need it actually receiving it. And that means there's still over 5 million people, and these are already 2008 numbers, still over 5 million people in need. So if we were to start all those hypothetically, using the cell phone study, and this is very hypothetical, it's a cross-section in time, but with the number needed to treat that we saw in our study, we're looking at least 400,000 or 500,000 less virologic failures in the first year. And you can imagine how that could contribute to poor health outcomes, as well as cost escalation due to drug resistance. So experience and feedback. Generally, the overwhelming feedback from small focus group discussions was that it felt like someone cares. A lot of people don't disclose their HIV status. They're living it. It's a very difficult time at the time of diagnosis, as you can imagine, and they really felt like this contact was really their support that got them through the initial stages, at least of dealing with their diagnosis and starting the medications. And at the end, it was very popular. 98% of those who were able to exit, said they wanted the program to continue, and 97% said they would recommend it to a friend. There were challenges, of course. You can imagine not everybody yet has a cell phone. There's still, but as I mentioned, it's the ingenuity and free market forces that are really driving that in the region, not aid. So I think that makes it much more durable in the long run, and it's increasing rapidly. Changes in phone ownership were a problem, but overall the system worked. So we didn't fuss too much with the details. If people changed their phone, they got a new phone, they were registered back in the system. And crisis management, we were actually, unfortunately, for the people of Kenya over this time, was the major political crisis over the 2007 turning into 2008 election period, where there was a huge crisis in the country with a lot of violence and death and internal displacement of people. And we found that our nurses at that time were actually able to guide a number of people to new places to get antiretroviral medications, or support them psychologically through give them counseling to help them get through the crisis. And we'll be looking a little bit more detail about the data effects on that. So in conclusion from this, we learned that cell phones are useful patient-centered tools for HIV/AIDS management. And I say patient-centered because we were really, they helped come up with the program first of all, and really it was about their support. It wasn't just about reporting data back to programs, but it was actually really around their needs and support. It was left wide open. So the SMS patient support system improved adherence to antiretrovirals and rates of viral suppression, and we now have at least one clinical trial to show that's the case. And I think there are a lot of logistical challenges, but they can clearly be overcome. And in process, as mentioned, the outcomes are still being peer-reviewed, but the WHO did an article as well as we were able to discuss it in the article in The Lancet about the idea that about the crisis a little bit, but the idea that it's really in response to an article that they had about streaming health resources over one disease versus many diseases. And I think we all share that same feeling. And I couldn't agree more that in this case we're looking at HIV as a source to build a system in need due to timing and resources, but clearly this is a health systems type of a platform that could support patients for many conditions, from tuberculosis, perhaps malaria, hypertension, even diabetes, and so on. And there are a number of studies actually in North America that show benefits in areas like diabetes and asthma. Although I have to say there's a lot of interest in this type of thing, and one of the things that I think our favorite was somehow it ended up on the program. I wasn't there even at the time. One of our colleagues who helps with the policy side showed us that the Kathmandu Post on their front page had an article about how Kenyans were using cell phones to improve their HIV management, and I think it was called Thinking Out of the Box. And so I can just imagine people, sitting waiting to go up big mountains and reading about what people are doing in Kenya to solve their solutions. And there were a lot of people, of course, that contributed to this. I have to thank first CDC, the PEPFAR program, that's the U.S. government President's Emergency Plan for AIDS Relief, through the Center for Disease Control, really funded the bulk of the study and provided us initially a little bit to get started, and then really supported the program as it went along, as well as a lot of collaborators. We have a wide variety of behavioral scientists and epidemiologist. Ed Mills here really helped with some of the how to approach the study aspect. And unfortunately, Dr. Rosemary Nguti, a statistician, has recently passed away from cancer during this period. But we had a really strong team in Kenya who contributed, and that, of course, includes all of the clinic team as well as the participants of the study. So we had a retreat this January just as we were starting to wrap up the trial and figure out how to look at the data, and that was a lot of fun. And on the bottom left are some of the patients who were very open and happy to promote. We had a lot of people requesting how do we bring this program to our setting, which I think is really nice when you're doing research and people are asking you how they can be involved. So the way forward, we need to look at cost-effectiveness data, and we have partners here at UBC in the core program that are helping with that. But I met with Ken Friedberg who's probably one of the top cost-effectiveness groups in the HIV world at the moment, and basically he said if it's effective, it's going to be cost-effective because really we're looking at very low cost. We want to do program-level evaluation, so we're not looking at just patient outcomes, but also the effects on the clinics and retention and clinic efficiency and that level as well. And the ICT automation and innovation. We have 3 pilot platforms that we've worked on and developed using either a smartphone to manage it, to automate it. One is using a SMS, bulk SMS machine similar to the internet, but not using the internet, and then one using the internet. And I think we need to really develop those appropriately for the setting and really look to scale up. And I think one of the most fascinating experiences for me, and I spent with my family, we went for 5 years to Kenya to work on vaccine HIV solutions and it's actually what we learned there and can bring back that's quite fascinating too. So this isn't new to people in Kenya who are very innovative in how they use cell phones. In fact, they're the first ones that in the world in Kenya where they did the M-Pesa program and they could text message funds. So a lot of people are now getting paid through text message where they just go to a local booth wherever they are and collect their money because they've received a text messages that allowed them to do that. And that program is being evaluated in Canada and other places after what was piloted in Kenya. And I think this is another example of ingenuity that developed out of the setting where we can actually look at what can we learn from that and do here. Because we all face many of the same human challenges of access to medication, cost constraints in our health systems, and so on. So now we're also looking at building how can we apply this type of thing to mHealth in BC, Canada, and beyond, and through the BC Centre for Disease Control, where we're looking a lot at marginalized and hard-to-reach populations on how can we support them. TB control is an obvious one, and perhaps even chronic disease prevention. And I think really looking at mobile populations, so people who frequently move from one destination to another are often some of the same people who are at risk, so you can see where cell phones would be an optimal way to support people in that environment, as well as remote and northern communities and Aboriginal communities. I think it could be very exciting as a tool to really connect people in new and innovative ways. So in some final slides, I think that it's obvious that cell phones are increasing at an incredible rate around the world. Globally, that it's expected that 4.5 billion people by 2012 will have access to cell phones. Look at that.
Nice timing, Rich.
I know. And mine's broken, actually, because I'm trying to turn that off. I
was just texting you there, guy.
Yeah. That wasn't someone in the audience, actually. But the resource-limited settings really have this leapfrog technology. They went from really no phone access to state-of-the-art and lots of innovative ways to use it. But I think the same can be said here, where we have a lot more legacy systems of hardline telephones and internet and so on, and we probably have to take a more integrated approach here. But the world is going wireless, and I think health systems and the health world needs to really be leaders and harness that aspect as well. And just in terms of the HIV pandemic and the neglected global disease, it's not fully neglected. People are aware of it, but we're nowhere close to being there. If you see this graph showing the number of people living with HIV, and that's just starting at 1990. Which were already at unacceptable levels, and it's still going up. It is plateauing. We're liking that, but still year after year the number is even higher. It's not lower. And you can imagine that in a disease that isn't curable, that's become a chronic disease, that getting this bar to come back down to acceptable levels is nowhere in our near future, even with all the breakthroughs. So we need to work on these breakthroughs, but they need to be long-term and they need to be sustainable, and they need to really get us through a long period of time. And so we'll be presenting a poster at the IDSA in Vancouver as well, and we're also excited to be presenting orally at the mHealth Summit in Washington, D.C. in November, which I think is really something like this, where we're trying to bring people together in drug discovery and access to care and so on, but really in the field of mHealth to bring people of all sectors together and discuss. And it's going to be keynote speakers, include people like I don't know who that fellow is on the left, but the fellow beside him is actually the chief technology advisor to the White House. So they're looking at it in the States as something that's becoming certainly part of the future, and I think globally that's the case as well. Thanks.
So we have time for questions for Rich. We have good 10 minutes. You want to show your video?
Okay.
You think we can do it?
Sure.
Of course, we may blow up the computer, but
yeah. The one from CBC you can actually access online, and that one has some very nice features. I think it's very well done. There's one from South African Broadcasting Corporation did. I'm going to try that one, and this one shows a gentleman who was part of the program, and the CBC one also focuses on one of the women at our clinic, both who felt that there was some benefit from the program.
Is a project being carried out by researchers from Kenya's University of Nairobi and Canada's University of Manitoba. The idea is to easily offer support to people living with AIDS and also encourage adherence to antiretroviral drugs.
But it could be used in a wide variety of health issues, not only HIV, but to monitor
He's one of the MPH students who
or receiving malaria
came to
treatment.
visit us in the
Statistics
program.
indicate that at the end of 2007, there were at least 280 million mobile phone subscribers in Africa, representing a penetration rate of 31%.
And the patients reported to have like over 90% had their own cell phones or shared access to a cell phone, but they were using these cell phones to communicate with relatives for business, but they were not communicating with healthcare providers.
Those who are being reminded on messages to take their ARVs. And
somebody else could have easily reminded Minor to take his drugs or even offered the much needed ear. But the stigma associated with HIV/AIDS remains high in Kenya. So a coded SMS offers the support and the privacy that he much needs.
we usually send the SMSs on Monday, then we give them 48 hours to reply. Then we call them, those who didn't respond, and find out why.
Minor lives alone here in a little wooden shack in Nairobi. His closest friend, his mobile phone.
In fact, I'm almost giving up. I'm tired of taking this meds, you know.
You feel like stopping the drugs? No. In the past few months, usually you get such difficulties. Most of them start their ARVs when they are very down, very confused.
Apart from reducing the visits to the clinic and easing the administration of drugs, health workers say the project has reduced their workload and is time saving.
One day I was very sick. I did not have a phone. I went to my sister and asked her to text the nurse and I got her.
The speed and the cost of the SMS, project administrators here agree, is life-saving for some of the continent's poorest people. With more Africans having access to a mobile phone than they have to a healthcare worker, the mobile phone could be the next big thing in healthcare management. Sarah Kimani, SABC News, Nairobi, Kenya.
Cool. That's great. Any other questions for Rich? Rebecca.
Hi, I was just wondering if you could comment on, I'm sure that you've looked at this as behavioral researchers, but reasons why people might text that they're okay but they're really not, or how do you look at that? And the non-responders, I know you prefer the non-responders, but I can see a whole bunch of reasons why you might not want to actually have follow-up for various issues.
Yeah, I mean, we can't, obviously there follow-up and the relationship between someone's engagement in care is very complex, and I think you're right. We need to look more closely at that, and I think we'll do our best to do that. I think we can't solve all of those problems with text messages, just like we can't actually deliver the care and treatment through the phone. Although there's probably innovative ways that people are coming up to try to do that. But basically, just that level of support seemed to be very important when we and one of the questions between the purists in the study who are trying to look at the question is it the reminder aspect, the cold reminder, or is it because it's Nurse Sarah who they love and respect and knows cares for them that's leading to the support? And I think I think it's important for us to understand the components of those. I would say the TLC component is actually is part of it, and I think it should be part of it, and I don't think we need to tease that out, because even if we scale it up in automated systems, I think we very much need to take into account the fact that it's knowledgeable people, respected people in the health system, and maybe those that are closer to the client themselves are the right types of people to be the end of the phone. It doesn't need to be them sending out all these mass text messages, but the person that you talk to might be somebody from your clinic or knows your case or who's very professional. So I think that TLC component is very important. We won't be able to completely tease that out in this study, but I would say this study has shown to be very effective without a twice daily reminder, and a lot of electronic devices that have been studied that do that type of reminder have not been so successful. So I think it's an important component.
There's a hand here. Yes.
You mentioned applying a similar approach to marginalized populations here in BC, but it seems to me that the cost of mobile phones is orders of magnitude higher here. Yeah. How would you address that?
Yeah, no, I think you're right. I was really shocked when I came and I had to first I bought a prepaid account and then that ran out of money, and not only could I not call the person back, but they couldn't call me either, and I felt stranded. And because in Kenya receiving calls is free. So I think it's more costly here. There's also a lot more resources here. I mean, we're really looking at people there who are often making $1 or $2 a day who are making it work. So in terms of how do we overcome those, I think you're right, those are real barriers and issues. In terms of cost effectiveness, I can certainly see how subsidizing phone services and access for people in need would be very cost effective or even cost saving for our governments and healthcare systems. So those are certainly things we'll consider.
Yep.
That's a great study. Folks who text back that they had an issue, can you give us some idea of what proportion of those could be handled over the phone versus how many actually generated visits to the healthcare providers?
Yeah, I think that's very important information. I don't have all of that data yet. The weekly responses was an awful lot of data, over 11,000, but we're looking at those. I think the feedback from talking with the nurses and clinical officers who ran the program was that it was usually about a health issue, but not always. Sometimes it was hunger or other problems that come up, or transport and other things. In terms of side effects in health, though, that was the primary issue that they were dealing with. As to whether they could help them solve the problem on the phone and avoid a clinic visit and therefore be more efficient in capacity building for the clinic versus having them come in, that's the sense I got, but we don't have the numbers yet.
Can you comment a bit on the scale-up or on the possible scale-up of this technology to other parts of Africa? My question is there a unique set of factors specific to Kenya that made it succeed, or are you optimistic that it could be scaled up too much?
I'm very optimistic that it could be scaled up for a number of reasons. Is that it's I think the health systems and the technology systems are very similar, at least regionally in East Africa and Sub-Saharan Africa, and other parts as well. And I think the other thing is that it's so simple in some ways, and it really just uses that human innovation and communication need aspect that I think that's a universal factor for adherence and improving patient outcomes. So I think I'm very optimistic that this could be representative of a regional, if not global, initiative. Yeah.
One last question? Yeah, that's good.
Did you guys look at literacy as an issue? Like, was there issues around that?
Yeah, absolutely. So we talked about... in fact, the nurses did choose to select people who didn't speak Swahili, even who maybe spoke Ma or other languages in that language. Ideally, if we automate it, we'll have people select languages that they're used to as well. But literacy itself, as I mentioned, there were examples where being literate wasn't a requirement to be in the study. Having phone access was. So having a partner who's literate or somebody who can respond to the text messages for you, and often that's the child in the house actually, who's the literate one who could actually fill that gap. So it's really about networking and support, and I think by keeping it simple, we increase the access, and then also by allowing those types of things, by keeping it simple, we could overcome that. It can still be an issue for some if someone is illiterate and hasn't disclosed their status, that would be an issue. Yeah.
Well, Rich, on behalf of the NGDI, thank you so much for coming out and presenting today. I'm kind of getting good at this. So here you go.
Well,
a token of your appreciation. We really appreciate it.
Yeah.
All right. Take care.
Thanks.
All right. Thank you very much.